So I'd just like to welcome everybody here tonight. My name's Peter Field, for those of you who I haven't met. And as you can see, I'm from the Dental Solution. So I'm the State Manager and I'm based here in New South Wales. Thank you all. This is our 6th webinar. There's obviously a lot of interest in treating patients for sleep apnea with mandibular advancement splints. And we have had 42 people register for tonight's webinar. The webinar will be available on the RDI website and also the TDSA website. So from the Respiratory Dental Institute tonight, I'm joined by
waiting for our small business owners. They don't just feel like the rioters are trampling through the street.
Yes,
just going to ask if everyone could mute. Everyone could mute their computers, please.
Every time, every single time I've not done it.
Brands that we want to project nationally or internationally. Is there anything that you would like to see police doing differently at this stage? Based on my discussions with police, it feels like they've really been trying everything they can. They've been trying different tactics.
There we go. Okay.
That was good.
Sorry, we'll go back to the start. Yes, if everyone could mute their computers, that would be great. We will have questions and answers at the end. And if you have any urgent or pressing questions that you think of, please send them through to me on chat and I will interject where appropriate. So I was saying from Respiratory Dental Institute, we have sleep physician, Dr. Linda Schachter. Linda, welcome.
Hi, Peter.
Thank you. I know it's been a fairly monumentous day in Melbourne with earthquakes and riots. So thank you for coming along tonight.
Melbourne is where it's all happening, is all I'd like to say.
And Michael, Associate Professor Michael Stubbs. Michael, welcome to you.
Thank you.
Thanks again for everyone for turning up tonight. I'm going to hand straight over to Michael, who's going to be talking about basically selection criteria, the right device for your patient, talking about temporary appliances, temporary trial appliances, and how to fit them. And then we'll follow up with a question and answer. So thank you, Michael, and I'll hand over to you.
Thanks, Peter, and good evening, everybody. Thank you for taking the time to watch us at the Respiratory Dental Institute. One of the questions both Linda, Peter, and myself have often been asked by colleagues who have done the course is, how do I know what type of dental device to use for my patient? Because there's a lot out there. And I thought I'd like to share a little bit, first of all, about some criteria that you might use for selection of the device. And I'm going to give you some examples, particularly in Australia, of some of the more common commercially available devices. And the other one I often refer to, particularly those of you who have done the RDI course, both introductory and advanced program, is I talk about a trial device. I'm going to share with you a little bit about a trial device, where you can purchase them, and more importantly, how you use them. So let's get started. One of the most important features about any mandibular advancement splint is the fact that it's two pieces. You need to have an opportunity for the mandible to be able to move laterally, because if you don't, some of those one-piece devices that literally locks the mandible in position, the patient runs the great risk of developing TMD, temporomandibular disorder. And one of the reasons is because it's very difficult, if not impossible, for the patient who wants to brux to actually physiologically brux. And so you generate much greater pressure or tension in the masseter and the temporomandibular joint regions. And so the other principle I think that's important to mention as well is the fact that devices must be adjustable. And we use the term titration, but basically it means that you wouldn't start your patient at 100% maximum position. In fact, if I may be bold to say, on an average, you would consider 50% of the protrusive range, remembering that for those of you who've done the course, you know that we teach you how to use the George gauge as a guide. And the reason I say that is because you need to allow the temporomandibular joint and musculature to adapt to the device. So 50% is usually a reasonable starting point for most people. Patients, certainly who have temporomandibular disorders, we would certainly set them at much less, perhaps 10 or 20% forward. And again, those who've done the course will understand why I'm saying this. Now, the Dental Solution in Melbourne, who in fairness are our sponsor, they make a product called the dorsal fin. The dorsal fin has some good advantages because it's movable. In other words, two pieces. It allows for lateral excursion. It actually allows for mouth opening. So if you have a patient, let's imagine, where they want to cough or they want to speak during the course of the evening, they actually can. They don't have that claustrophobia sensation of being locked together. And you can see actually in this photograph, and I'll just show you the next one, where we've got a magnified version of the devices. You'll notice that there on the left-hand side of the slide, on the left image, there's a block mechanism with an arrow, and that's the adjustable component. So if you can imagine this was in your patient's mouth, and then they took it out and you want to advance it, you would actually use an Allen key. You would work out, roughly speaking, how often and how much you need to advance it and teach the patient how to do it. So for argument's sake, you might get them to advance the Allen key in this little tiny middle sprog here. You can see there's 3 bars. You turn clockwise, and as a result, the block moves forward 0.1 of a millimeter. And consequently, when it's in the mouth, the fin moves forward 0.1 of a millimeter, therefore the mandible does. And in the particular design that this one has, you can see there's some metal reinforcement. It's just to try to reduce the probability of fracturing of the fin, because sometimes, particularly in patients who are quite ferocious bruxers, they can actually fracture the fins. And it's something that we try to minimize the possibility of that happening for obvious reasons. We don't like a patient waking up in the morning with a device and there's a piece missing and they're not sure where it's gone, because sometimes you worry about in the lung or, of course, in the stomach. And SomnoMed are another well-established Australian company that manufacture devices. This is a good example of one of their unique ones we call the Fusion. Now, the value of me showing you this is, unlike, say, the dorsal fin, this has interchangeable fins as well. So not only do you adjust it using the blocks, the advancement blocks in 0.1 millimeter increments, but also, as you would probably be aware for those of you who are familiar with our course, that this block has a maximum of about 5 to 5.5 millimeter advancement. So imagine if you had a patient who had 11 millimeter protrusive range and you started them at 5 millimeters and yet they needed to go to 6 and you only had about 5 or 5.5. What you do is these fins can be removed, and each time you change it to the next fin, you're actually adding a millimeter. So in reality, you have 5.5 millimeters, and then each of these fins change, adds another 3 millimeter. The value is particularly those cases, those colleagues who work in regional areas where the requirement to take the device off the patient and send it back to SomnoMed and get this thing rejigged so that you can continue to move forward and the patient doesn't have their device for 1 week or 2 weeks, depending on lockdowns. It's not really very acceptable. Whereas with this, it gives you the chance to make those adjustments yourself rather than sending it off to the lab. Again, same principle. You're looking for movement, opportunity to open and close the mouth, lateral excursions, freedom of movement, and also, more importantly, the titratable aspects to the device. The Herbst, particularly those of you who are familiar with orthodontics, would recognize this. This one's been around for about 30 years. And it's the concept where, again, you've got the 2 rims. And again, in this case, you don't have a fin or a block. You actually advance with the key, Allen key here, where I'm scribing. And as you're turning it forward, you're bringing the mandible forward in, roughly speaking, about 0.1 millimeter increments. But more importantly, the arm extends. And so it actually means that the patient has a reduced range of lateral excursions, but it also is good for bruxers because sometimes you'll find that the fins that are shown in dorsal fin and the SomnoMed one, they can fracture off. Now, again, when we design a splint, if you have a patient who has let's say, a significant bruxism habit, friendly advice from my perspective would be consider not just the splint, but in the design of the splint, perhaps consider putting an anterior block or a lug, if you like, between, say, 2 to 2 of the opposing arch, or 3 to 3. And what it does is it actually stretches the separation of the rims and gives more clearance towards the posterior element of the device, which, as you know, through the curve of Spey, is often thinner than the anterior part. So it reduces the likelihood of fracture. And again, with this, I find these are quite useful for patients who have very small mouths, but also those patients, such as ladies, but particularly the patient who's a gagger, because it reduces the bulkiness in the cheeks. And again, for the benefit of patients who are profound tooth bruxers, it actually helps reduce the likelihood of you fracturing the mechanism, which allows you to advance. So again, you'll choose the device that best suits your patient. And this one is called the MDSA, which sounds rather impressive, but it just means medical device for sleep apnea. And in this case, again, 2 rims. The difference is the attachment is anteriorly. Now, there are, of course, a variety of devices that exist now. For example, some labs, big one in Melbourne, makes the nylon devices, which look like an MDSA, but pretty much are made of nylon. But in reality, the benefits of this approach is that because the attachment is at the front, there is a very good argument for minimizing mouth opening. Because when a patient has the device in the mouth, if their mouth opens, what often happens is, as you can imagine, let's imagine in this situation with this one, you have the patient with the mouth open in a relaxed position. What happens? Well, the mandible slightly distalizes, particularly as they open. More importantly, the tongue does. And so we know that if we can keep the mouth, relatively speaking, closed, we also are encouraging nasal breathing, which is also very important. You ask any ear, nose, and throat surgeon, and they will validate me saying that. And in the end, what you're trying to achieve is reduction in snoring, as well as improvement of the airway, and trying to minimize the degree of advancement. Because remember, correlation of severity of the occlusal changes, which occurs in all devices that advance the mandible, it doesn't matter what design we use, if you can get a good outcome with minimizing the extent of the protrusive range, that's a benefit to your patient, because in fact you're reducing the severity of the occlusal changes in most cases, but also more importantly, keeping the airway or the mouth closed is actually a big positive. And that's one of the reasons why, even though these are a bit of a dinosaur now in the world of sleep devices, they're still a very useful device. And you can see here, this is an example of an MDSA. It's got the 2 parts to it. So really simplistically, 2 rims, and it's got a plate on the bottom. And you can see there's a hook attachment on the upper, the anterior region. The hook engages into the plate, which allows for lateral movement of the mandible. And the titration or the advancement is done by turning a key in the front. And it brings the mandible forward about 0.25 millimeters. So you can see here, this is the device in situ on the models attached. And you can imagine as the patient tries to open and close their mouth, they can't, but they can certainly move from side to side. Benefit is it reduces mouth opening. Perhaps disadvantage is if you have a patient who's got a claustrophobia sensation or a concern about inability to open their mouth, compliance will be poor. The other thing I have to tell you is, because I've fitted lots of these myself in my career, often you'll get pain associated within the anterior front teeth, because that's the mechanism of attachment. So you'll often find when you fit these that you'll often be adjusting initially anyway, the contact area of the anterior 3 to 3 on the upper and lower arch, because that's where most of the pressure tends to occur. Again, it's got advantages, and those advantages are particularly, it's a tough cookie. So again, if you've got a bruxer, you really got metal on metal. So the probability of fracture is less. And more importantly, it does prevent mouth opening. And so colleagues often say to me, you know, if I have a patient, what can I do? I mean, let's say for argument's sake, you have a patient who's got a diagnosis of sleep apnea. They can actually rent a machine, a CPAP machine, for a month, and they can trial it. And if they don't like it, they return the machine, and okay, they've bought the mask, which might cost them $90, $100. But in the end, they've made a decision that it's not for them. With mandibular advancement splints, one of the problems is we make great customized devices, but it is, and it has been to more recent times, a concern where, you might say, well, if your patient spends a lot of money on a device and they say, look, the device is beautifully fitting, I can tolerate it, but it's not doing anything for me, nobody feels good about that. And so what we do is we recommend two approaches. The first one is, this is a boil and bite concept. It's made by an English company called Sleep Pro. And this is the one that I use commonly on my patients as a trial device. You can see on the image on the left side, it's got the two boil and bite rims. So this is an acrylic. The thermoplastic material is on the fitting surface. And these straps are predetermined measures of about 2 millimeter increments. So what I do is I'll determine the range of movement protrusively. So let's imagine it's 10 millimeters. I would then say to the patient, okay, let's prove that this is going to be useful for you, because you'll find that most patients who come and see you, believe it or not, it's not so much about the sleep apnea, it's about the snoring. And snoring is an incredible motivator for patients, despite having sleep apnea, to actually get the treatment. It's quite amazing. It still amazes me. And I've been doing this for nearly 20 years. And so by doing something like this, where you would put it in boiling water, it would be softened, you'd fit it onto the upper teeth, you'd ask the patient to bring their mandible forward until you get to the desired position. They bite nice and hard, counting to 20 to themselves, opening up, take it out, you chill it under cold water, and it becomes a one-piece device, which I know goes against what I said about customized mandibular advancement splints. But folks, this is not a customized device. This is something intended for 1 or 2 weeks use. And it's actually a very important element, in my opinion, because this is the proof that demonstrates to the patient that when they go all the way with a custom device, they're going to get a good result. I also use these for patients, let's imagine, who are using CPAP and they say, look, I want an alternative, but I'm not sure if it's worth it because I don't know how it's going to work. What I'll do is I'll make them a trial device. I'll advance their mandible forward. They'll have a sleep study with the trial device in the mouth, and we get some objective data based on that to see how efficient it is. And again, it brings confidence to the fact that if the patient's getting a reasonable result with the trial device, if they have the custom one, they either use the custom one when they travel, keep the CPAP for home, or they shift over to the mandibular advancement splint, knowing that it depends on which study you're looking at, but about 40 to 60% of patients in CPAP users are deemed to be what we call intolerant. So in other words, they're not that compliant, they don't like the device, they don't use it all the time. They might only use it or wear it for about 3 to 4 hours and take it off their face. The dental devices in severe apnea cases are clearly not as good as a CPAP, but the reality is patients' compliance is better. Patients will go to bed with a device in the mouth, they'll wake up with it in the mouth. And even though on the average, when you look at the data, you might not get the sleep apnea events down from, say, over 30, which we deem as severe, to less than 5 events, which we deem as normal. We can, in fact, demonstrate that for 60% of patients who have severe apnea, we can get their numbers down. And we also realize if they're prepared to wear the device or not, they're better off than having a well-made, well-fitting CPAP machine, which works for 3 hours, and then they have about 4 hours without any treatment whatsoever. So trial devices, in my opinion, have a really important role to play, both for demonstrating efficacy of a mandibular advancement splint, whether it be feedback from snoring, or more importantly, having a sleep study to see how efficient they would be working before they went all the way with a custom device. Now, for those of you watching this program, I'm happy to say to you that these Sleep Pro Contour devices are commercially available online for $159. If you type in the word Stubbs RDI, the UK company have actually offered to make it for $35 a device, which is a pretty significant saving. And the reason I'm saying that to you is because I believe that this is a reasonable thing for you to try. It's certainly a low-cost way of demonstrating efficiency. So this is one of my patients, and unfortunately, the sound didn't come through with the brilliant recording. So you've got the person fitting the device doing the narration here. That's me. But I'd like to just demonstrate what I shared with you in reality in a real life situation. Those were the days we could have haircuts, Peter.
Yes,
Lockdown. Okay, so I'll get back to the subject. Here we go. Now, can people hear that?
I can't hear it at this end, Michael.
Right. So what's happened here is I have fitted the warmed up trial device into the mouth. I've left it in there for about 20 seconds. I've advanced the mandible in a forward position. And then I've asked him to open his mouth and I've taken it out. And then because it's warm, I'm running it under cold water to chill it. And you can see the patient there is very enthusiastic, waiting for the trial device to be reinserted. So then what we do is I now fit it. And I'm getting him to bite nice and hard. And then I'm checking that he can breathe. He's not sure at the moment. And his lower jaw is now sitting in the forward position. And then again, I take it out. And here we have the very happy patient giving me a nice smile and demonstrating that it's actually quite stable and retentive. So the point I'm making here is you'll see in the image, there's a space between the upper and the lower rim. So you get mouth breathing, which is really important. I mean, we want a situation, don't we, folks, where we don't want to say the treatment was successful, but the patient died because they couldn't breathe. So the aim of here is to make sure we hold the mandible forward, but also enable mouth breathing to a degree and nasal breathing. And these things last for about 1 to 2 weeks. And so what I do is when I fit them, I say to the patient, for the first few nights especially, that's when they'll get their most important feedback. Now, sometimes some people aren't in a position to get feedback on snoring. So what I advocate is SnoreLab. SnoreLab is a free download app that you can recommend for your patients. Patients can usually for free, they'll get 3 nights worth. They do not have to listen to themselves snoring when they get up in the morning. What they do, it expresses diagrammatically the severity of their apnea. It's either mild, quiet, mild, loud, or epic. And obviously we don't want loud or epic. And it gives an idea to the patient just how loud they are with the device in the mouth versus without it. Again, simplistic, effective. The other option, of course, is the partner's elbow. And a lot of my patients will swear by the fact that their wife, because a lot of our patients are obviously men, remembering women can have sleep apnea and snoring issues too. In Australia, about 20% of women snore, 40% of men do. But it's amazing the number of patients who I've had who are male will often tell me their wife before they turn the light off says, have you got that thing in the mouth? So, you know, it does demonstrate a degree of efficacy, and it's something very simplistic and temporary. And again, it brings confidence to the patient that when you make the device, you can then choose not just the right one for them, but more importantly, they know that it's going to help them as well as you do. And again, another happy, smiling situation. So just on those simple topics, folks, tonight, I certainly invite questions, but I thought we would also like to say to everybody watching this that the next webinar will be on the 13th of October. Remember, these are free. These are something that we like to do to share our knowledge with our colleagues. And we do it because we're happy to do that. And so your support by attending these webinars is much appreciated. And we hope to see you online certainly next time. So any questions?
Michael,
Yeah.
Sorry, Michael, if I could just ask one question.
Yes.
Of the patients that you've treated with a temporary appliance, how many patients go on to have a permanent appliance made?
About 95%.
About 95%.
Yep. It's that simple. And, you know, it's not complicated to do. It takes about 5 to 6 minutes to fit. And it's amazing. About 95%. And the other thing I like about it is the 5% that don't like it or found it didn't work. Okay, they've spent money on a trial device, but they walk away saying, well, at least I gave it a go. The worst part, I think, as a clinician is you charge a patient for a beautifully made, custom-made device, and then the patient says, well, it's a nice-looking device, it fits beautifully, but it's not helping.
Yeah, yeah. Michael, there's a couple of questions here. Does the trial device affect occlusion?
Not in the short term, no.
Okay.
So what you'll find is your patient will tell you when they take it out in the morning that they're hitting their anterior teeth initially. They'll also complain about pressure or discomfort on the anterior teeth because of the mechanism of attachment, a bit like the MDSA I showed you earlier, where the attachment apparatus at the front tends to predominantly cause pressure at the front. What I often say to a patient is, well, the real one, obviously, the custom one won't do that because you have the chance to adjust it. So you can actually make sure if there is any pressure points on the custom one, you can easily relieve those areas. And secondly, it also, because it's a proof of concept, even if the patient only wore it 1 or 2 nights and they got a positive impact, then that's all they need. I don't mind saying to you, I give my patients 2 weeks to try it. And I've had lots of people ring up in a couple of days and say, I want the appointment for the real one. So it's actually a very useful tool to demonstrate efficacy. And I have to say again, we do use them also when we're doing sleep studies. Even with when Linda, Dr. Schachter does sleep studies for us as well. If we have a patient where we're not sure if the trial device is, the mandibular advancement split will be suitable, we will make a trial device, do a sleep study, and with the benefit of the data, we actually get great confidence that we know we're treating the patient most appropriately.
Michael, there's another question here. How do you adjust the mandibular advancement with the trial appliance?
Well, what you do is you'll see, I'll just go back in the slides just to show this. Just here, you can see these straps that are attached. These are a predetermined length. So this, in real terms, probably advances the mandible, let's say 4 millimeters. So you actually would remove these straps there, they click off, and you put the next size up. So you bring them forward 6 millimeters. And so these straps come in what we deem as size 0 up to size 8. Now, in my time, I've only ever gone up to the size 4, which is 0, 2, 4, 6, 8, 4 maybe once or twice in all the years I've been doing it. Most times it's 0. Sometimes it's number 2. So what you do is if you get a patient with your George gauge who has, imagining, say 12 or 15 millimeter advancement, I would easily start them much more forward with a strap number 2 than I would a 0. Most patients, interestingly enough, it's strap 0. And so you just preset it.
Michael, for snoring patients with narrow nasal airway, what are your thoughts on orthodontic treatments like dome technique or widen the nasal airway?
Well, I think widening the nasal airway is important, and I know Linda would have some interesting things to talk about that too. Just from a dental perspective, I mean, certainly orthodontic treatment, I think when you're dealing with a younger patient, I'm talking, pubescent age, up to say 16, even older, but particularly with kids, those patients that have the very narrow maxillary arch, the deep palatal vault, there's great advantages in intervening with orthodontics to expand the upper arch. But when you're dealing with adults, to expand the palatal, the hard palate, you're obviously talking about sectioning the hard palate because, as you know, it fuses at the age of 12. And so then they'd have a rapid maxillary expander to expand the upper arch. And so I think what I'd be advocating is if I treat an adult and the conversation of orthodontics comes up, I will say, yes, it's useful, but I'd also be looking at more specific treatments for the nose. And Linda, if you wouldn't mind sharing your experience in treating patients who have nose problems.
Look, thank you, Michael. I think the nose is incredibly important in actually snoring and sleep apnea, because obviously if you've got a blocked nose from whatever cause it may be, it's going to contribute to mouth breathing, it's going to contribute to upper airway inflammation, all of those sort of things. So it's incredibly important. Now, you know, obviously if there's an anatomical component to it, so it depends what that anatomical component is. If the person's got allergic rhinitis, then treating it with nasal steroids may be appropriate. If they've got blockage because of a deviated septum, then, or it may be appropriate to send them to an ENT surgeon. So I'm a big believer in, no matter what treatment that you do for snoring and sleep apnea, the nasal passages need to be patent, and you need to be able to breathe through your nose. And realistically, we do selectively if we can. So you know, if you, for whatever reason during sleep, if you can breathe through your nose, you will, unless there's an area of blockage where you'll open your mouth to compensate for upper airway or partial or complete obstruction.
Thanks, Linda.
Thanks, Linda.
A question from Willem. What is the best follow-up regime with appointments once issuing a permanent appliance?
Good question, Willem. What I do is I always give the patient 2 weeks to get used to wearing the device. I think one of the friendly tips I'd suggest is when you fit them, most of the times they've got a flex liner. Sometimes they don't, depends on which design you choose. But the point is, try not the temptation to adjust them a lot when you first fit them. If the patient says, oh, this is a bit sore here, a bit of pressure here, because what happens is you'll find if you're a bit aggressive with the adjustment, visit number 1, when you fit it, usually visit number 2, and they come back 2 weeks later, they start complaining it's loose. And I would then follow them up at the week 2 and get some feedback. So it might be feedback from the partner on snoring. It might be a sense of refreshment, very subjective, I know, but useful. And then depending on the diagnosis, if they had obstructive sleep apnea, we would then start to work on the premise of titration. So if it's mild sleep apnea, and again, I appreciate Linda's a sleep physician. She'll have a lot more to say about this, but usually a lot of sleep physicians find that if the patient has mild apnea and the patient reports subjective improvement in sleeping better, refreshment in the morning, they don't normally mandate a repeat study in most cases. Certainly moderate to severe apnea cases, they would, and I think that's fair. And so we would work together on the advancement or the titration process. That might be every 4 to 6 weeks I'd review the patient. For my patients, I teach them how to advance it. I tell them how much to do over that period of time. And then ultimately they would be sent back to their sleep physician to actually have a repeat study where we can actually get some data to make sure they're in the right position.
Very good.
And just following up with that, the other thing with it is, yes, if the patient has simple snoring or mild sleep apnea and they're under good control, while I wouldn't do a study immediately after they've had a split made, whereas I probably would with moderate to severe sleep apnea, I would still do an annual study, or for at least first couple of years after they've had the split made, because I want to, I suppose, give the patient the impression that this is an important condition that needs to be monitored long term. So it's really important that you do organise annual follow-ups and to get data at that annual follow-up to make sure that the patient realises how important follow-up actually is with it. So I, as a sleep physician, do see these patients once a year, looking at symptoms and also making sure that the sleep apnea and snoring is still treated. Also, obviously, over time, they may put on weight, other things may happen. So there may be other issues contributing to problems as well.
Yeah, that's a great point. And with the dental devices too, I always review my patients once a year. And I do that because devices can crack, they can loosen, especially the mandibular one. If it starts to lose retention, its efficacy starts to reduce. And it's always great to follow up patients because of the occlusal changes. You get an idea, a comprehensive idea of just how severe the changes are and how the patient is functioning overall.
Michael, we've got some more questions for you. What advice will you give a patient in terms of occlusal change long-term in a permanent mass appliance? That's from AJ. Thanks,
AJ. I have to say, we recognise that about 98% or more of patients will get an occlusal change. It varies in intensity. The biggest problem we have, I think, from a scientific perspective is we can't say there's no algorithm to demonstrate severity of occlusal change as a prediction. So what I do is I say to my patients, part of looking after them, I include in the cost of the device. I do a 6-month follow-up. So in other words, over the course of the 6 months, they'll probably see me between 3 and 6 times or as many times as needed, and then once a year. I also advise the patient that most occlusal changes will happen between the first 6 months to 3 years. And so I also then recommend that once a year, we're always checking the occlusion. I say to patients, if they decide they're not happy with the occlusal changes and they want to reverse it, if they stop wearing the device, there will be some improvement, but the occlusion is never the same as what their current CO is. And most people, if you say it like that, will say, well, look, you know, I'm not too fussed about my occlusion when it comes to my health. Or the fact they'll say to me things like, well, you know, the fact that I can stay in the same room as my partner rather than down the other end of the house, it's the price I'm prepared to pay. Internationally, the view is that that's the price you pay for the treatment. So if you have a patient, and let's imagine you do a trial device. I did one recently just for a patient who wasn't sure whether it was for him. And he tried the trial device for a week. He rang up and said his jaw's been really sore. It's taken him a day to get the jaw back to closing properly. And I think the conclusion was pretty simple. Mandibular advancement splint's not for him. And I think it's a fair call to say that with occlusal changes, even using the trial device, if the patient's dissatisfied, even with the 1 to 2 week trial period, that they feel there's discomfort in their teeth, they don't like the pressure feeling, they don't like the way their anterior teeth don't align in the morning, you've just saved yourself a lot of hassles because that mandibular advancement splint is not for them. Now, I'll tell you another interesting observation. Those patients may go on to CPAP and then they might come back to you. So it's interesting, you're educating the patient. But to answer your question, unfortunately, there are no algorithms you can use. There's no absolutes. All you can say to the patient is, if you're a betting person, you've got about a 98% chance it will happen. It won't happen overnight. It will take 6 months to 3 years, and you'll be following them up at least once a year to help give an idea of how they're progressing.
Thanks, Michael. Question here from Westham, and I think you've already answered the first part of the question. That was about a temporary device causing any effect on occlusion. But can the temporary appliance also be used as a temporary occlusal splint? Say if we are waiting for a permanent splint.
Look, it's not manufactured for that purpose, Westham, but I don't mind saying if you only use the upper rim and the little button attachment at the front, you'll have to burr them off, but you could. It's a relatively low cost way of doing it. I use the aqua splint, the aqualizers, because I find they're the ones that are disposable. They're little saline sachets that sit between the opposing dentitions around the 6 areas. I find them more useful, but you could do that too. If you wanted to, you could use just the upper rim, but do trim off the button at the front so it's flat.
And I think this is the last question. I'm sorry, I'm just going to have to scan through. Bear with me. Can orthodontic treatment be done concurrently or after the permanent device has been worn for some time to allow for an ideal occlusion with an improved mandibular position?
Look, the reality is once you introduce orthodontics, their mandibular advancement splint clearly doesn't work.
Yeah.
One of the things I do too is I look at the MAS and I say to the patients, look, you might start off with a mandibular advancement splint, and just imagine hypothetically, patient has the device, the custom one, they get a great result with their sleep study follow-up. They might then look at surgical procedures, orthodontic and orthodontic procedures to actually advance the mandible. And you see, that's a valid proposition because in my opinion, we know that when we advance the mandible, we actually had a very good presentation earlier this year from a max fac surgeon in Melbourne, Mr. Eddie Newen, who talked a bit about orthodontic surgery. And he said that, you can advance the mandible up to 13 millimeters forward, depending on the case. And so you actually have a huge impact on the soft tissues because they come with it. And so if you had a patient successfully wearing an MAS custom device and they got a good result with their sleep study, there would be a very strong argument if they wanted to have orthodontics and orthognathics together. I think that'd be reasonable, because your problem would be if you get them in a desired position with an MAS custom and then they go for orthodontics, they're going to have to go on CPAP because you can't use obviously a mandibular advancement splint while they're having orthodontic treatment because the teeth are shifting or changing. And then at the end of it, you would then replicate the position of where you'd like the MAS to start. But I have to tell you, you might run the risk of some minor tooth movement. So my advice would be, if the patient wants orthodontics, you might get them to have a custom-made device, look at it as a step-by-step process, and then look at orthodontic surgery if that's a possibility for them. Remember, not every patient's medically fit enough. Not every patient wants orthodontic surgery, but there are a lot of patients that would prefer to have surgery and orthodontics rather than be attached to a device or a CPAP hose.
Thanks, Michael. And this is a comment more. So there are clinicians who do phase 2 treatments, which are just orthodontics and not orthognathic to replace MAS. Is this reliable?
Well, I have to say up front, I don't believe so, because if you look at the science behind what you're doing, if you're changing the occlusion, when the patient sleeps at night, what happens? The mandible drops back. We see sleep apnea in class 3 skeletal patients. So the occlusion is secondary to the treatment of the sleep apnea, not a primary motivation in treating it. Unfortunately, with the MAS devices, it's a side effect, the changes of the occlusion. But if you just did orthodontic treatment only, that patient means they still probably would snore. You might give their tongue more space, but they still could snore. And certainly with sleep apnea, it's not just about the tongue. We understand that the airway obstruction or narrowing is related to the soft palate, the collapse of the pharyngeal wall, and the tongue base collapsing as well. So you could have a beautiful occlusion, but they can still have sleep apnea after the treatment.
Can I ask a question, Michael? If you've got a person with a positional sleep apnea, rather than somebody who has sleep apnea in every position, do you find that you need as much protrusion if somebody's got positional sleep apnea?
No, because usually if the patient sleeps on their side, they usually, as you know, score less. So we can get away with the advancement being less. That's absolutely right. And the night shift, for those of you who aren't familiar, is a device that you can buy, which has a vibrator on the back of the neck. And if you lie on the neck, it vibrates and induces you to turn over. Some people use I think they still do, don't they? Linda, tennis ball.
Tennis ball in the back of your pajamas.
It's a cheap one. But either way, it just keeps you on your side. It works. But yes, you're right. I mean, you don't have to advance it as much.
Okay. The other, just one quick comment, Michael, just to let everybody know that when people do rent a CPAP nowadays, they can often rent a mask as well. So while, just to let people know, there's not quite the cost of when, in the last few years, they've changed it. You don't have to buy the mask. And part of that is because the mask that somebody gives you when you first start on CPAP may not be the mask that you end up. So rather than spending all this money on masks as well, there's a rental period for a mask as well. And they're obviously sterilised and stuff between patients. So that's really, I suppose, one of the newer things that's happened in the last few years is that all of the equipment's rentable now. And if you don't like CPAP, you can give it all back and you're not out of pocket hundreds of dollars.
And Linda, while we're there on that, because that's interesting, would you mind explaining to our audience watching a little bit about your level 3 that you do? Because there are a lot of colleagues that might say, well, look, I just want my patient tested for sleep apnea, and just imagine they snore, and then you decided that you'd make them a trial device to see if it works for snoring. Would you mind just explaining perhaps a little bit about your level 3 devices that you use for colleagues?
Yeah, for sure. We'll just go. So just when we're talking about level 3, we're talking about sleep testing. So there's obviously a multitude of levels of sleep testing. Level 1 is an inpatient sleep study or polysomnogram. Level 2 is home-based polysomnography. polysomnogram, which is basically a sleep study at home. So very similar to level 1, it's just unsupervised. And then we get down to level 3 and level 4, which is screening tests. And basically they don't measure EEG. So you've usually got a variety of signals, and they're usually nasal pressure, their oximetry, and usually there's respiratory bands. So there's a respiratory and abdominal band, and some of these devices will also have position. So the idea of these devices is a bit of a screening test to actually see if the person's got sleep apnea or simple snoring. So it's not a full sleep study because we don't see sleep, so we don't know that the person's had REM sleep. But the idea is to give an indication as to the severity of the sleep apnea and whether you can make recommendations, because one of the problems with sending somebody for a sleep study, as Medicare have made it more and more difficult to do it, by the time you refer to the GP to get a referral for a sleep study, so the more steps you put in the process to get somebody actually diagnosed, the more likely you are to actually lose that patient along the way. So a level 3 test is a simple test. If it's actually positive, the person has sleep apnea. If it's negative, it doesn't mean they don't have sleep apnea. So it just means that we're not actually seeing it on the test itself. So the idea is, so that you can diagnose simply snoring or sleep apnea, and then quite simply you can actually monitor how the treatment's going without requiring expensive invasive tests and requiring people to go for inpatient studies or home-based studies because of the limitations that Medicare puts on it. So the idea of it is a simple way to test. It can be done. You can have a device in your rooms where you actually put it on, or get one of your nurses to put it on, or show the patient how to put it on the night that after the consultation with yourself. Results come back within 2 to 3 days. So the idea is to actually get the patient into a treatment program quite quickly, and obviously the normal delays aren't there.
Sorry.
That's all right.
So, and then it can be done repeatedly, obviously, to make sure that, you know, whether you do it as a titration tool. So there's level 4 studies that even have less signals. But the idea of it is to actually, I suppose, monitor what's happening as you adjust the device itself. I do believe that after the permanent device has been made, that somebody should have a sleep study to check. Obviously, that's more in the moderate to severe sleep apnea, to check that the device is working. I've got to say, in 25 years of doing this, I've only seen once where the mandibular advancement splint actually made the sleep apnea worse. But obviously that is possible to do so if you do change the dimensions of the upper airway.
Linda, thank you. I can't see any more questions from anybody at this stage. So I just wanted to say, on behalf of us all, thank you, Linda, and thank you, Michael, for the presentation tonight. Thank all our participants. I think we got up to 25 there at one stage, which is fantastic. Thanks everyone for turning up tonight. If this is an area that you're interested in, obviously you can visit the Respiratory Dental Institute website. The 6 videos that we've done to date will be on the site, and you can have a look at the courses that are available. And on behalf of the Dental Solution, we would like to thank you for your ongoing support. Obviously, the Dental Solution, we have sleep appliances, occlusal splints, here to help also. So Linda and Michael, thank you so much. It's been a great evening and lots of really, really good questions. So thanks again. And there's nothing but thank yous coming through on the chat line now. So thanks, everyone.
Thank you.
Thanks for coming.